Welcome to this explainer. Today, we're diving into a case-based clinical journey, covering one of the single most common and honestly most frustrating presentations in healthcare: low back pain. If you're a primary care physician, a physiotherapist, a nurse practitioner, or an orthopedic specialist, you know exactly what I'm talking about. A patient walks in, clutching their lower back, desperate for answers, and usually hoping for a quick fix. So let's look at the latest evidence together and figure out how to best navigate this, all the way from acute triage right through to chronic care.
Okay, before we jump into our cases, we've got to set the stage and look at what we're actually treating here. Did you know up to 84% of adults will deal with low back pain at some point? It's incredibly common. But here's the really important part. When you look at the data, the vast majority of these presentations in primary care, over 85%, are completely nonspecific. That means the pain is happening without any specific identifiable underlying condition that we can point to on a scan. Less than 15% involve a specific pathology, things like radiculopathy or spinal stenosis. So the key takeaway right out of the gate is that most of the time we're dealing with mechanical, self-limited pain, not some dangerous underlying disease. Here is our roadmap for today. We'll start with triage and red flags, move into acute care to bust some common myths, tackle the subacute and occupational phases, and finally hit chronic care, interventions, and surgery.
All right, let's get right into case 1. Picture a 45-year-old construction worker sitting in your exam room. He's got 3 days of acute, localized lumbar pain after hauling a heavy beam at the job site. Naturally, he's asking for an MRI to see, quote, what's broken. We've all heard that exact phrase, right? So what do? Do we image him? This right here is the absolute most crucial first step in our clinical workflow: risk stratification and triage.
The evidence gives us a genuinely striking number here. Less than 1%. Out of all the patients showing up in primary care with acute low back pain, less than 1% actually have a dangerous underlying etiology, like cauda equina syndrome, metastatic cancer, or a spinal infection that actually requires urgent advanced imaging. For the other 99% of people, early imaging does not improve their outcomes. In fact, it's usually counterproductive. It often just highlights normal, age-related wear and tear, which freaks the patient out and cascades into a whole bunch of unnecessary interventions. So for our construction worker, unless he's showing very specific red flags, an early MRI is absolutely not indicated.
So, what exactly are those red flags? I love using the ABCDE mnemonic here. It makes checking for dangerous causes so much easier. A is for aortic aneurysm. You're looking for flank ecchymosis or lower extremity ischemia. B is for bone fracture or bleeding, which you'd suspect if there's trauma, osteoporosis, or a recent spinal procedure. C is for cancer. Keep an eye out for a history of malignancy or unexplained weight loss. D is for disc-related emergencies like cauda equina syndrome. If you see saddle anesthesia or progressive motor deficits, that's an immediate MRI. And finally, E is for epidural abscess or other infections, usually flagged by a fever or IV drug use. If your patient doesn't have any of these, you can confidently presume a diagnosis of acute, non-specific low back pain.
Now, assuming there are no red flags, how do we treat this? The approach has completely shifted over the years. The guidelines call out some heavily outdated practices, telling patients to go on strict bed rest, ordering those early MRIs just to be safe, and handing out opioids. We now know for a fact that this over-medicalized approach actually delays healing and pushes people into chronic disability. Today, evidence-based practice is all about keeping the patient moving. We want activity modification, not bed rest. We only image for the ABCDE red flags, and for symptom relief, we lean heavily on non-pharmacologic therapies like superficial heat paired with the right first-line meds.
If superficial heat and basic modifications aren't quite cutting it, we follow a very clear escalation ladder for acute pharmacotherapy. Step 1 is always education and reassurance. You have to explain that this pain is self-limited and that moving around is actually safe. Step 2 is our go-to first-line systemic medication, NSAIDs, like ibuprofen or naproxen. Step 3, if they're having severe spasms, you might consider a short adjunct course of skeletal muscle relaxants. And step 4 is acetaminophen, or paracetamol. Now, this used to be everyone's first choice, but current evidence actually says it shouldn't be first line anymore, because it just isn't that effective for back pain. But you can still trial it if your patient has strict contraindications to NSAIDs.
But honestly, knowing what not to prescribe is just as critical. We have to strongly avoid inappropriate prescribing for acute, non-specific back pain. That means staying away from opioids, sedatives, neuropathic medications like gabapentin, and antidepressants during this phase. Opioids and neuropathic meds really don't offer clear benefits here. And worse, prescribing them early on is strongly linked to a much longer duration of work disability for the patient.
Okay, moving on to case 2. Let's say our construction worker is still having pain past the 4-week mark. He's officially transitioned into the subacute phase. He is back at the job site, but he's terrified to lift anything because he's convinced he's going to blow out a disc. How do we manage this occupational subacute pain? Well, at this stage, the clinical picture usually shifts. It's less about purely physical tissue healing and becomes a massive psychological and behavioral challenge.
This is where we need to be on high alert for psychosocial yellow flags. When back pain starts impacting someone's job, psychological factors and poor expectations become the main drivers of chronic disability and delayed recovery. You need to actively screen for fear avoidance behaviors, pain catastrophizing, feelings that their workplace or supervisor doesn't support them, and underlying depression or anxiety. If you spot these yellow flags, your patient is at a really high risk for staying out of work for a long time.
So how do we get them back on track? First, grab a validated functional tool like the Oswestry Disability Index, so you can measure objectively exactly what they can and cannot do. Next, look into ergonomic assessments and something called participatory ergonomics, where the worker actually helps figure out the solutions. But the biggest thing, we have to highly encourage an early return to modified work. The evidence is incredibly clear on this. Getting back to work, even in a limited, modified capacity, gives patients massive physical and mental health benefits compared to just sitting at home waiting until they feel 100% healed.
A huge hurdle right now is kinesiophobia. It's exactly what it sounds like, an intense, irrational, and really debilitating fear of movement. The patient firmly believes that pain equals damage, and they are terrified of re-injury. This is why early patient education is just so absolutely crucial. We have to look them in the eye and reassure them that a little bit of mild discomfort during a graded return to activity is totally normal and perfectly safe. Early referral to physical therapy is fantastic here to help desensitize them to movement and break that cycle of fear. All right, case 3. It's been over 12 weeks now. We are officially in the chronic phase. Unfortunately, at this point, the chances of a spontaneous 100% recovery drop pretty significantly. We aren't just waiting for an acute tissue injury to heal anymore. This is the exact moment our clinical focus has to shift away from simple tissue healing and pivot toward advanced physical rehabilitation and behavioral interventions.
For chronic care, we start integrating cognitive and behavioral modalities. Why? To address central sensitization, which is when the patient's nervous system is essentially stuck on high alert. Cognitive behavioral therapy, or CBT, is highly effective for tackling those negative coping behaviors. Mindfulness-based stress reduction and pain neuroscience education are also great because they literally teach the patient the neurophysiology of their pain, which takes the fear out of it. And for patients who are severely impaired, the gold standard is a full multidisciplinary rehab program that combines intense physical exercise with psychological therapy.
There's actually a really fantastic quote from the evidence here. No single exercise technique has superiority over others for patients with subacute and chronic low back pain. As clinicians, we often agonize over prescribing the absolute perfect physical therapy routine, but honestly, whether it's yoga, Pilates, motor control exercises, or just walking on a treadmill, the specific modality matters way less than simply getting the patient to move consistently. If you can find an exercise the patient actually enjoys and will stick with, you have found the right therapy.
Now, what if conservative care just isn't working? This is where we absolutely have to distinguish between radicular and non-radicular pain. Radicular pain is classic sciatica. It shoots down the leg in a dermatomal pattern and might cause weakness or reflex changes. Non-radicular pain is nonspecific, localized right there in the axial back, and it doesn't have those focal neurological signs. Making this distinction is vital because it's the primary driver for figuring out if your patient is a candidate for interventional pain procedures.
If your patient has unmistakable radicular pain or symptomatic spinal stenosis, and they've genuinely put in 6+ weeks of conservative therapy, meaning real physical therapy, exercise, and meds with no improvement, then we can consider interventions. Epidural steroid injections are usually the most appropriate next step for radiculopathy that isn't responding to non-surgical care. But please keep in mind, these procedures are generally for specific radicular symptoms, not your run-of-the-mill non-specific axial back pain. Keeping that straight prevents us from putting patients through invasive procedures they don't actually need.
Finally, when do we actually pull the trigger on a surgical consult? The rules here are incredibly strict. We refer urgently for severe or progressive motor weakness, or obviously any signs of cauda equina syndrome. On an elective basis, we might refer someone if they have persistent, severely disabling radicular pain that just isn't responding to any non-surgical care. But it is so important to remind our colleagues and our patients that minor neurological deficits, like a mild foot drop from a disc herniation, often recover perfectly fine with conservative management. They do not automatically mean someone needs to go under the knife.
To wrap up our clinical journey today, I want to leave you with a bit of a provocative question. Could our traditional approach to non-specific back pain actually be causing the exact chronic disability we're trying to prevent just by over-imaging and over-medicalizing these patients way too early? The evidence is pretty clear on this. By trusting the guidelines, skipping the unnecessary MRIs, avoiding quick-fix opioids, and instead focusing on empowering patient education and early movement, we can radically improve patient outcomes. Thank you so much for joining me on this explainer. I really hope this gives you some practical tools you can use in your clinic tomorrow.